Hey. How are you, Daniel? Good. Can I run that from here, or you can transfer it, because I have just a couple of spelling changes.
There you go. Oh, let's lower this. That's way too high. Oh, you're wearing a sweater. Ugh. I'll do this. Sorry. And then we can just clip this one to
this
that
one?
one. No, that one's the room mic. Whenever you're ready, flip the switch on top and then it'll turn on. This is the recording mic.
So I have to have both of them?
Yeah. This is just for the recording up there, the camera.
Okay, so
this one you don't have to mess with at all.
Okay.
Just put it in your pocket.
Okay, so I'm wired like a strive to
Yeah.
start our movie. And this one I switch it on, right?
Right.
So where is that?
You just flip it like this.
Oh, and that's on.
Yep.
Okay.
This is, I think you've used this one before,
Yes.
but forward, backwards. Pretty much it.
Okay.
You good? You're pressing backwards.
Good afternoon, everyone. Sorry to be 10 minutes late, but I thought it's in the house, so I was waiting there. Then I realized I should call someone. So we are going to talk on melanoma today. It's a brief update regarding what exciting happening in the field of melanoma. This was a malignancy just 2 years back. There was nothing much in terms of the metastatic disease. And from oncology standpoint, we used to talk in terms of weeks to few months or couple of months. We have reached a point now that we can even talk about from months to year probably, and that's excitement. And I'm going to focus a little bit on ABS and EBS, that's antibody treatment and immunotherapy in the field of melanoma. So these are the topics I'm going to briefly overview: thickness, margin, importance of that, pathological risk factors, interferon data, that's the treatment for melanoma in adjuvant setting, meaning after the surgical resection, the role of sentinel lymph node biopsy, role of complete lymph node dissection, radiation therapy, immunotherapy, targeted treatment, and what should be the plan for surveillance. I think the toxicity from the immunotherapy and the targeted therapy is very important from internist standpoint, because the ability to recognize that those side effects are happening from the treatment actually could be very important to institute proper treatment in appropriate time. So the melanoma incidence, 5th most common cancer in man and 7th most common in women in USA. The tumor thickness is most important predicting factor in terms of deciding how their prognosis will be. So if we see in this curve that the number marked as 5, and that's 2 millimeter or more. So when the size of the melanoma goes 2 millimeter or more, or that thickness is associated with an ulcer, their overall survival drastically drops. And that's the reason early diagnosis in terms of the thin melanoma and proper excision based on the dermatological recommendation with an appropriate margin is very important. This is taken from the SEER database, and we can see that the majority of the melanoma will be still early stage melanoma. So truly, like prostate cancer, it's a disease managed by dermatology, like prostate cancer managed by urology. When it becomes more challenging disease to treat, when it develops lymph node involvement or the metastatic disease, then it comes to us in terms of the oncological management. Survival is quite significant and really encouraging in early stage disease, and that's why proper early detection and resection is very important. Unfortunately, in the distant disease, the survival is still very discouraging. And again, as I said, even as we have been able to take it from months to year, it adds to a lot of excitement in the world of oncology. The new cases are slowly growing up. There is not a good explanation for that. It could be early detection, more vigorous surveillance, but we are also noticing the thick melanoma is getting diagnosed in a higher frequency. So if surveillance will detect more melanoma, we do expect them to be all thin melanomas, not thick melanomas. Again, this graph been formed from American Joint Commission of Cancer and their database, and it again shows the importance of the lymph node involvement and the importance of the lymph node involvement when the lymph node clinically palpable compared to the sentinel lymph node biopsy showing the lymph node involvement. As the more lymph node get involved, the survival curve slowly declines. And the same thing is true when the clinically lymph node is negative, but the pathologically positive, meaning sentinel lymph node biopsy showed they have a better disease-free survival and overall survival compared to when it's clinically positive. So implication of the stage and survival, again, important thing is early diagnosis. When it is less than 1 millimeter, the number is really good, more than 90%. Increasing thickness that we already talked reduces their chance of overall survival and the risk of disease coming back. As I was just talking, lifetime risk of developing melanoma is on rise in this country. In 1935, that was 1 in 1,500, and 2010, it has drastically gone up. Yes, it could be that we are doing a better job in terms of picking up early lesion. There is also some change in terms of pathological diagnosis. They are using better technique in terms of immunohistochemistry and can detect melanocytes which could be not feasible to diagnose 20, 30, or 50 years back. This is the most recent, the staging system by American Joint Committee of Cancer stage changes. The most recent staging system came out in 2010. So this graph is from that. So you can see here, even in stage 3 disease, that is depends on how many lymph nodes are involved, or there is a lymph node involvement clinically or not. If somebody has a stage 3C disease, their prognosis is the worst compared to even individuals who has a stage 3A disease. LDH has implication like lymphoma. In a lymphoma, LDH high predicts poorer outcome. Now the data shows the same thing holds true in melanoma too. Not all melanoma who will have elevated LDH, but if at diagnosis, if the melanoma has elevated LDH level, that is considered as a poor prognostic factor. And again, those individuals has a worse outcome compared to someone who has a normal LDH. So it's not consistently related all the time, but we do follow LDH level in someone with metastatic melanoma, because if their LDH level is going up, which went down after treatment, which could be an early sign that micrometastatic disease is hiding somewhere. What are the risk factors? Familiar risk factors and origin is absolutely one of the important risk factors. Irish and Eastern European ancestry put individuals in higher odds of developing melanoma. I think light skin pigmentation and hair color goes with the Irish and Eastern European ancestry, and that has significantly increased risk. High nevus count, more than 25 nevus, increases the risk. Sun and ultraviolet rate exposure, especially using tanning bed, and if those happens before 35, that has extremely high risk of developing melanoma in subsequent age group. Socioeconomic status not necessarily predict or increase the risk of development, but it predicts poorer outcome. Individuals with impaired socioeconomic status has probably melanoma diagnosed in the advanced stage, and for that reason it has a bad outcome. Probably many of you have seen recently published data on citrus food using and increasing risk of melanoma. It has shown significant risk, 36% higher in people who consume citrus fruit or juice, and 1.6 times daily compared to those who doesn't consume it. Center for Disease Control at this point do not make any specific recommendation not to have citrus food because the data is not precise, and in a population study it needs to be proven beyond doubt. The researcher who actually published the data, he also made the same comment. But the conception is citrus fruit has this chemical, pseudocuramines, and the belief is it makes the skin sensitive to ultraviolet rays related damage, and that's why it has a higher chance of developing melanoma. So the suggestion at this point is if you do like to consume citrus fruit, it's best to probably have processed juice rather than having real citrus fruit. And another idea is beyond 1970, the recommendation or push to eat or drink citrus fruit has gone up significantly because the belief is it helps to prevent atherosclerotic disease, boost immunity, and the bump we are seeing in the melanoma, if it is truly hand-to-hand relation, is probably related with that increased consumption of citrus fruit after 1970s and 1980s. Types of melanoma, there are two broad categories. One is related to the sun damage, chronic sun damage, and another is not related to the sun damage. So if somebody has a melanoma in the uveal or the scleral area, if they have melanoma inside the buccal mucosa, and I'll show some pictures, then those melanomas are non-chronic sun damage. Chronic sun damage melanomas and clinical subtypes are superficial spreading. In superficial spreading and lentigo maligna, sometimes there is a difficulty in getting proper clear margin. So many times dermatologists recommend doing a staged excision, meaning doing the biopsy, checking the immunohistochemistry, making sure the immunohistochemistry negative, and then stopping it, otherwise going and re-excision again. Nodular melanoma is overall most challenging one because it could be deceptive in terms of the growth of the melanoma, because it looks like a tip of the iceberg, but it may have much higher depth of invasion inside the skin, and which could put the patient in higher odd of disease recurrence. So this is lentigo maligna. You can see that kind of has spider-like tentacles or octopus-like. So that's why it's difficult to get a clear margin around it. This is the superficial spreading, most common type. Acral lentigious melanoma, again, is very difficult and challenging to diagnose because an odd location, common in even African American individuals living in sub-Saharan area, because if you are not wearing a shoe and your skin and the sole is exposed to warm sand, that can cause chronic damage in that skin and can cause melanoma. Due to the challenge with the diagnosis, it could be advanced before it is diagnosed. And this is nodular melanoma. And as you can see, this picture is taken from up to date. And again, the depth of invasion could be higher, although in the superficially it looks much smaller melanoma. So this is uveal melanoma. They have significant challenge in diagnosis. Many times they have a tendency to present with hepatic metastasis, an advanced stage, and this is buccal mucosa with the melanocytic changes. So that screening examination, New York University first developed that back in 1985, and we used to call it A, B, C, D, and now an E also been added. The E is the evolving lesion, if it change in size, shape, or color, or new lesion. There is a more comprehensive one, that's the Glasgow 7-point checklist, and they have divided that in the major and minor criteria, and based on that we can use both on conjunction or can be used with just ABCD with E and make the diagnosis in terms of whether those individuals needs further excision or biopsy and what screening examination needed. This is probably more important from the dermatological and internist standpoint rather than the truly being an oncological issue. This is a picture of skin, and I think the anatomy of skin is very important. So when we are reading a melanoma pathology report, I would like to see my pathologist is explaining that the melanoma starts from the epidermis, involves basement membrane, and gives me a depth of invasion where it ends. Does it goes up to the subcutaneous tissue or does it end in the dermis? The reason behind that, if my pathologist tells that melanoma was solely present in dermis, but the epidermis and the basement membrane was intact, then my concern is that melanoma may not be a local melanoma. It could be a melanoma that started somewhere else and in transit to go and end up in the lymph node, or that melanoma could be a metastatic deposit from another melanoma in somewhere else. So a good pathological description or diagnosis is absolutely important, and those are more important when the melanoma's location or the primary location mentioned in the pathology report, dermis or subcutaneous tissue, but the upper layers are not involved. So there is a complex staging system by AJCC, but this is a more simplified look to remember easily. Local disease is considered 1 and 2, regional disease is 3. Any lymph node involvement will make it a stage 3 disease. That's the simplest way to remember. If there is no lymph node involvement, it could be stage 1 or stage 2 disease. So when the size is the fourth point matters, 1, 2, more than 2 or more than 4. That's the important in size, and then in lymph node, as I mentioned. 2 nuances on that lymph node staging. If the lymph node, there is an in-transit mets, so in-transit mets is considered as that what I was explaining. There is a nodular deposit present in dermis or subcutaneous tissue, but the lymph node is not involved, then it's designated as N2C category. But when there is a in-transit mets with the lymph node being involved, that is considered as N3 disease. From my standpoint or oncological standpoint, it doesn't matter in terms of what treatment they will be receiving, but absolutely it matters in terms of the prognosis. There is no differentiation in the treatment, somebody with a stage 3A or stage 3C disease. Science has not gone that far yet, but again, definitely somebody with a N3 disease has a much worse prognosis compared to somebody with a N1 disease. So tumor thickness is important. As the thickness gets larger, the excision margin should be larger too, to ensure a complete excision of the melanoma. And multiple studies been done. Some of the studies done by the dermatological organization, some of them is done by the surgical societies. Even World Health Organization did a study to find out which could be a safe margin to do that. So they found out, in prospective data, when it was in situ or less than 1 millimeter, if the margin is 9 millimeters, so close to a centimeter, there is a chance that 99% of the melanoma will be completely removed. So that's based on that, National Comprehensive Cancer Network and American Society of Clinical Oncology came up with this recommendation. If a melanoma is more than 4 millimeter, there is at least need of 2 centimeter clear margin. So if you're reading a pathology report and you see there was only a 1 centimeter pathological margin, then that patient needs to go back, had a staged excision to make sure that margin is clean before coming back for further retreatment evaluation. So what are the important pathological factors? From my standpoint, I take a look at that, and that is also important from pathological standpoint. Those 3 are most important. Mitotic rate. So the Clark's level used to be considered as important prognostic factors. With finding out now with the newer technology that we can precisely tell how many mitotic rate are present. Any mitotic rate, as you say, more than 6 will be extremely higher chance of disease recurrence and higher advanced stages. Microsatellitosis, when the more than 0.5 millimeter present in the dermis that I was explaining, and in-transit met when the melanoma started somewhere but is in the process of going in another tissue or the lymph node. The other factors are present like tumor infiltrating lymphocyte, peripheral and deep margin, which is quite reasonable, but those 3 are most important in terms of the pathological risk factors. So this is a slide I kind of simplified the whole recommendation to give a bird's eye view from the internal medicine standpoint that what we are doing in oncology. Stage 1 disease, A means there is no ulcer. It's truly a dermatological disease, and those patients will probably not see any oncologist in their lifetime except their dermatologist. Stage 1B, meaning B means ulcer, so there is a small tumor, but they do have ulcer, and stage 2A is a little bit larger, less than 2 millimeter, but no ulcer. Those patients also probably will never see an oncologist. When we reach this point, 2C, meaning when the tumor is more than 4 millimeter, but no lymph node involvement, or we go to the lymph node involvement, or we go to the metastatic disease, at that situation, our role comes in play. In all the newer treatment that I'm going to show you guys in next few slides only comes in the stage 4 and very few in the stage 3 disease. So again, this stage 1 and stage 2 disease is highly curable and managed by the dermatologist. When it extends to stage 3 and stage 4, then only our role comes. So diagnostic workup like breast cancer, sentinel lymph node biopsy is standard of care now in melanoma. Not all melanomas do need that, but if there is a more than 1 centimeter in size or they have an ulceration, in those situations individuals do have to have a comprehensive sentinel lymph node biopsy done. So that is sometimes challenging, because if somebody has a melanotic lesion on their scalp, which lymph node is their draining lymph node? At that situation, probably they need sentinel lymph node biopsy of the both sides of the neck. If they have a melanoma in their leg, they need sentinel lymph node biopsy of the inguinal lymph node. And those are done by surgical oncologists who are trained to do this sentinel lymph node biopsy rather than a general surgeon. The PET scan, although we do in clinical use many times to make sure there is not a distant metastatic disease, but the sensitivity or specificity of the both of them go higher if their stage is higher. So if it is a stage 3 or stage 4 disease, or they have a thick melanoma or ulcerated melanoma, the PET scan has probably a more defined role compared to early stage disease. So in early stage disease, surveillance is still by the means of dermatological surveillance, good history and physical, and pretty much that completes without any imaging workup. So this is the definition on when we need to do the sentinel lymph node biopsy. If it is smaller than 1 millimeter, we usually do not need unless they have a high mitotic rate. As I was discussing in the other side, that mitotic rate is considered in higher risk factors, and definitely if they have ulceration, then we do need to do sentinel lymph node biopsy. Once the sentinel lymph node biopsy comes back, if it shows positive, is there any role of doing the lymph node dissection? I'll show in next few slides. There's probably a role in terms of reducing the disease recurrence in that nodal basin, but there is not much role in terms of overall survival. So implication of the sentinel lymph node biopsy, a phase 3 trial confirmed that important staging tool. They have a better relapse-free survival compared to when we just observed a nodal basin. Unfortunately, in the immediate thickness melanoma, that only showed some improved survival in terms of the disease-free survival and melanoma-specific survival, but in the thick melanoma or the thin melanoma, the benefit was not significant. And again, at the bottom line, it didn't show any overall survival benefit. But it is recommended to, as a purpose of staging, because someone can be clinically node negative, but pathologically they may be node positive, and in terms of guiding their overall follow-up plan or surveillance and prognosis is absolutely necessary. So lymph node dissection, if someone has a sentinel lymph node positive, the data showed that they have 18%, in 18% of those situations, they showed further lymph node involvement during the dissection. If their location of the deposit mattered, if they're subcapsular versus parenchymal, or the large size of the sentinel lymph node metastasis kind of predicted the chance of more lymph node involvement. There is an ongoing trial, MLST2, which will answer finally whether complete lymph node dissection has an impact on outcome yet or not. So far, there is no impact in outcome found out at this point. There are few specific locations. If there is a cloakweight lymph node, which is the superior most lymph node in the inguinal chain, is involved, or more than 3 superficial inguinal lymph node, or as I was sharing that melanoma in scalp area, in those situations, completion of a post-sentinel lymph node biopsy and lymph node dissection is important, and it showed decreased chance of recurrence in those nodal basin. There is a recent trial came out, it's a European data, and they looked at the same conception after sentinel lymph node, whether there is any benefit of doing lymph node dissection versus observation, and again, distant metastasis-free survival was not significant. But the North American data is at this point still in clinical trial and has a much large patient population compared to this trial, which has merely 500 patients. So we believe that ongoing trial will give a precise answer regarding this dilemma. So this graph actually showed individuals with having observation versus sentinel lymph node biopsy in recurrence. In intermediate thickness melanoma, you can see there is a difference or separation of graph. Unfortunately, in the thick melanoma, the graph actually merged with each other, which proves pathobiologically a thick melanoma or ulcerated melanoma will have a higher chance of distant recurrence compared to an intermediate thickness melanoma. Again, the same thing is true with the melanoma specific survival, and when the observation was done, they had a higher chance of the disease coming back when they was truly negative, and when the sentinel lymph node biopsy was truly negative, they have a better overall survival. Again, in the thick melanoma group, they have not been proven to be successful. So there are few malignancies where immunomechanism plays a role, and we have even anecdotal case report back from 1970s, 80s that individuals with renal cell carcinoma has multiple lung nodules, and after 6 months they came back and X-ray showed no lung nodules. So we realized there is an immune mechanism involved with that, and we knew in melanoma also there is an immune mechanism because as I will talk, interferon and interleukin being used in melanoma, and interferon and interleukin very much tweaking the immune mechanism pathway and helping for disease control. Based on that conception, further research being targeted. There are main important cells are CD8 and CD4 lymphocyte, and then the T cell receptor interact with major histocompatibility complex, and the CD3 molecule transferred that data intracellular downstream effect, and that helps in the immunity. So immunologically naive CD8 T cell or T cell receptor, they need presence of this co-stimulatory signal CD28, B1, B71, B72. At the presence of the co-stimulatory signals, T cell receptor can interact with major histocompatibility complex, and that stimulates CD3 to release that signal, and that releases these cytokines. So far till 2010 and 11, we are just using this treatment for melanoma. Researchers are looking out whether they can target these sites and can make the immune mechanism even faster or prevent body's immunity to have a checkpoint, almost letting the brake go in a car or pushing the accelerator, so the immune system in the body can itself take care of the malignancy. So there are some inhibitory signal present with the antigen presenting cells and the T cells, and most commonly those are targeted are programmed cell death receptor or its ligand, and cytotoxic T lymphocyte associated protein or CTLA4. And these are the other targets, and these are in the clinical trial. Even with those, sometimes what happens if the melanoma or the malignant antigen consistently present to this T cell receptor, they will be exhausted at one point to continue to do the immune mechanism or immune surveillance to kill those malignant cells. And that's one of the known mechanism or evasion from immune surveillance, and that's why as the metastatic disease burden in stage 4 setting is so high that beyond a point the treatment is not feasible to continue to keep the disease under control. So how we treat melanoma? In a stage 3 melanoma, the first question is to ask, is the lymph node is positive or lymph node is negative? If it is positive, is it clinically positive or the positive through the sentinel lymph node biopsy? If it is positive through the sentinel lymph node biopsy, at that situation, as no data showed overall survival benefit, we only say consider or offer complete lymph node dissection. If the patient has symptoms like shortness of breath, bone pain, or headache, we can address further staging requirement, and we may have a discussion regarding using interferon. Again, I'll show in the next slide that interferon did show when initial trial came out in 6.5 years follow-up that it improves disease-free survival and overall survival. But when the 12 years data came out, overall survival benefit fell off. So again, in oncology, most important thing I would like to see, there is a benefit of overall survival. And if a trial can really show overall survival benefit, that trial has the gravity and probably will be in the clinical setting quickly. Ipilimumab is a cytotoxic T lymphocyte CTLA4 antibody, and I will discuss briefly. Again, this treatment has also showed disease-free survival benefit, but no overall survival benefit. So based on that, the strength of the recommendation is weak, and it's a category 2B. So in a young patient, it could matter, and we'll still probably recommend. But if somebody has 65 or 75 and they have other comorbidities, it's probably not prudent to pursue those. Same thing in clinical lymph node positive. If the clinical lymph node is positive, then we'll offer a FNA to prove that. And in that situation, probably there is no role of sentinel lymph node biopsy because we know already it's involved. In stage 3 disease in transit, that we were talking, that patient has a melanoma which is present in the subcutaneous tissue or present in the dermis, but no other primary location is being found, those are considered as stage 3 disease. And in stage 3 disease, some vaccine trial is shown some success, and that gets the category 1 recommendation. But the population in the stage 3 in transit group is very less compared to truly somebody being sentinel lymph node positive or clinical lymph node positive. Isolated lymph perfusion is done in transit disease too, which is, say someone has a in-transit mets only in leg. So they will block all the lymphatic circulation of that limb and give melphalan, which is a chemotherapy infusion. This is done in a very center-specific way. In this area, Duke only does that, so it's not a treatment that commonly available everywhere. And again, bottom line, it doesn't show overall survival benefit. If somebody has a nodal recurrence, meaning you did all the treatment, they are in observation, or they got their treatment and now the disease is coming back, then we need to prove the disease is related to the recurrent melanoma. And then if no previous dissection was done, meaning the patient did choose not to have a lymph node dissection after the sentinel lymph node biopsy last time, this time it's actually recommended. If previous dissection was done, then we can address from the surgical oncology standpoint to even further resect out residual disease, and at that time consideration will be palliative radiation versus systemic chemotherapy or immunotherapy. If distant recurrent disease is present, there is not much defined role of metastatectomy, meaning a lesion taken out from the liver or from the lung, knowing there is a higher chance of having a second recurrence somewhere else. So probably in those situations, close monitoring with PET imaging would be helpful to see whether those lesions are truly malignancy related or not. Because if somebody has a spot in their lung which is 5 millimeter, neither PET nor CT will be helpful, and we cannot do any biopsy of that small area either. So many times, even with an isolated metastatic disease, either offering systemic treatment versus observation could be an option. If metastatic disease is present, at that situation, all this treatment comes. We have immunotherapy, which are pembrolizumab and nivolumab, which targets PD-1 receptor. And then we have vemurafenib in combination with cobimetinib and dabrafenib in combination of trametinib, which are BRAF and MEK inhibitor. And those are recommended to use if someone has a metastatic melanoma with BRAF mutation positive. And then in the second line setting, it's recommended to use ipilimumab, which targets a different immune mechanism, the cytotoxic T lymphocyte 4. The reason that ipilimumab being pushed to the second line setting is because the cytotoxicity. When ipilimumab was approved back in 2012, it was in actually category 1 for the first line setting. When these newer drugs been developed, pembrolizumab and nivolumab, even in a face-to-face trial, it showed improved overall survival compared to ipilimumab and better side effects profile. So that's why this drug has now found their place in the first line setting, and ipilimumab has gone to the second line setting. Intraleukin high dose, we'll talk a little bit. It needs an advanced setting like ICU monitoring consistently to give that infusion, because it can cause many side effects, hypotension, even hallucinations, schizophrenia like psychiatric changes. But some of the patients receiving intraleukin in the past showed they are actually cured and stayed disease-free even 10 years after infusion. But I doubt in today's medicine having this other targeted therapy available, anyone will go to the interleukin treatment that fast. Probably if somebody is young, healthy, and has still progressed after multiple options, then could be a possibility. Imatinib, which is the same drug that we use in CML, can be used in melanoma if melanoma has c-KIT mutation. So the two mutations that we now look for in melanoma in a metastatic setting, this mutation is not recommended to check in a stage 1 or stage 2 disease. And if they have a BRAF mutation, then our treatment is directed towards the BRAF mutation. If they have c-KIT mutation, then we use imatinib in that setting. If they have poor performance status, multiple comorbidities, advanced stage, knowing overall poor prognosis of metastatic melanoma, best supportive care is very reasonable. Adjuvant radiation, again, melanoma is such a disease, radiation doesn't have much role in adjuvant setting, meaning giving it after surgery. One role of melanoma, if somebody is in advanced stage or have comorbidities and they cannot get resection for a stage 1 or stage 2 melanoma, definitive radiation could be feasible in that situation. Like complete lymph node dissection, the phase 3 trial that recently published last year showed radiation does reduce recurrence in the nodal basin, but it doesn't do nothing in terms of the overall survival. National Comprehensive Cancer Network, which is another parent organization in terms of putting forward recommendation that how to treat or what to do, they do not provide no consensus statement regarding whether to use radiation or not, because lymphadenema and other comorbidities that can subsequently develop from radiation is quite significant. So there is a great amount of split in terms of role of radiation or whether it could be incorporated in the treatment planning or not. So adjuvant therapy, meaning systemic therapy or systemic immunotherapy in melanoma after the surgery. And if we go back and remember that schematic, there was some role in stage 3 disease. So there are two vital studies, one is ECOG 1684, another is 1690. And as I was explaining, in the 6.9 years follow-up data that showed a significant relapse-free and overall survival benefit, but the longer follow-up showed the overall survival benefit not there, but the relapse-free survival benefit is still there. And the treatment in this protocol used interferon for the entire 1 year of treatment. And that was quite challenging to use in many patient population because there's so much side effects in terms of neutropenia, depression, fatigue, flu-like symptoms that happens with interferon. Beyond that initial 4 weeks phase, it's difficult to complete the treatment for 1 year. And probably that's the reason that eventually overall survival fell off from this trial. So side effects from interferon, acute constitutional symptoms that I was talking about, granulocytopenia. LFT needs to be closely monitored because dose modification may be needed. Patient needs to be screened for depression. If somebody has a significant psychiatric issues even before, they may not be a candidate to bring in this drug. Thyroid dysfunction, because it's an immune treatment, so any kind of autoimmune dysfunction can happen. It can happen in the thyroid, it can happen in the adrenal. So monitoring TSH is important. So ipilimumab, as I was talking about, so ipilimumab initially was approved back in 2012 for metastatic disease. Most recently, last year, it has also shown role in terms of disease-free survival in stage 3 disease or adjuvant setting. But unfortunately, still it has not got gravity of the recommendation from the organizations because significant treatment-related mortalities. There were 5 deaths in that study. One of them was from Guillain-Barré syndrome. And many of these patients, beyond 1 year, they couldn't complete this treatment. So yes, the trial showed disease-free survival benefit, but from our standpoint, it still needs to be pragmatic in terms of what we are trying to achieve or what goal that we are setting for the patient. Definitely, it's a valid discussion, and if somebody wants to pursue, we'll definitely encourage that, but knowing there is a significant chance of toxicities with this treatment. Another puzzling thing is in metastatic melanoma, the dose that FDA recommended is 3 milligram, and here the dose they use 10, which is quite significant. So using that higher dose could have caused that increased side effects. So there are further clinical trial is ongoing using the same drug, using a different dose and different weekly schedule. So maybe that will show a better outcome compared to this trial showed recently. So this is the data regarding high dose bolus interleukin 2 therapy, and complete remission was approximately 6%. So one portion of the curve, and you can see this is the all responder, this is the complete responder, and this is partial responder. all the curve get plateaued at one point. So some individuals getting interleukin therapy, and there is case report that they lived even 10 years, 15 years after interleukin therapy. So it's a common board question in oncology that which drug only has shown overall survival benefit in metastatic setting, and interleukin-2 is the answer for that. So immune mechanism, as I was showing in that picture, there is a physiologic break in our body. The CTLA4 receptor gets stuck with the antigen presenting cell, and the immunity stops there, and they do not kill the malignant cells or do not cause harm to our normal body cells. So when we are using ipilimumab, it is basically taking that break off and letting our body's own immunity go forward and kill the malignant cells. When we are using this other two drugs, nivolumab and pembrolizumab, which binds to the PD-1, it is actually pushing the accelerator to go the immunity forward and kill the malignant cell. In that way, we'll have a better disease control. So this is a nice picture and to depict what is going on. So this is CTLA4. In ideal situation, this will bind with the B7, and binding that which actually neutralize the tumor immunity. Or on the other hand, it can happen the PD-1 will bind with the PD-1 ligand in the tumor cells, and that way tumor cell will evade the immune mediated killing. Now if you use this anti-CTLA4 antibody, which is ipilimumab, it will go and connect with this. So this is blocked. Now B7 can interact with the CD28, and immune mechanism can move forward and do the immune clearance of the malignant clones. The same thing can happen with the PD-1 and anti-PD-1. So if anti-PD-1 is present, it will go and bind with the PD-1 and not let the immune cells evade that immune mediated killing of the cells. So those two areas now been manipulated, and those drugs, nivolumab and pembrolizumab, been developed in terms of using in metastatic melanoma. Trials are ongoing using those two drugs in adjuvant setting or stage 3 disease, and we are really optimistic those two drugs are going to show some benefit in terms of the overall survival in a reasonable toxicity, so we can use those drugs in the adjuvant setting too. So this is the drug that been developed between March 2011 and 2014. From 1980 to 2011, there were only 3 drugs in melanoma world: interferon, interleukin, and dacarbazine. Dacarbazine is one of the chemotherapy drugs. There are many chemotherapy drug combinations being used in metastatic melanoma, but unfortunately, even disease-free survival was not stretched to weeks. So all those fell apart. But once the researcher looked into the immune pathway and started developing this drug, and also the targeted pathway, between these 5 years, there was a almost overflow of drugs. And each time American Society of Clinical Oncology has their annual meeting, there will be at least 4 or 5 articles will come out of that in terms of showing the beneficial role of this drug. So pembrolizumab, in short note, it's an antibody to PD-1, as we talked about. There are 2 trials I would like to mention. One is the trial Keynote 002, another is 006. This is the first trial which FDA gave approval to pembrolizumab in using in metastatic setting. But it compared that with the chemotherapy drugs, not against ipilimumab. So that's why pembrolizumab was approved that time, but probably using in the second line setting after ipilimumab failed. Then this trial came out, and that it compared that against the ipilimumab, and overall survival was better in both groups where they got pembrolizumab. Not only that, toxicity was much less compared to the ipilimumab. So that based on that Keynote 006, from the first line setting, ipilimumab was pushed to the second line setting, and it has now consensus category 1 recommendation in terms of using this drug in the first line treatment for metastatic melanoma, provided they do not have any mutation like c-KIT or BRAF. The second drug, nivolumab, also was tested in multiple trials, and as I said, further trials are ongoing. The first trial was in Checkmate 066, and that was tested in untreated BRAF wild-type patient, meaning they don't have BRAF mutation. And again, they compared that against the standard chemotherapy at that point, and it showed overall survival benefit and progression-free survival benefit. With that data, then further trial was implemented, combining that with the ipilimumab and then combining the monotherapy. So far, progression-free survival data is available. Overall survival data has not come out yet, and in untreated melanoma, nivolumab is now, as like pembrolizumab, is standard of care for equivalent benefit or better benefit and definitely better side effects profile. See, the side effect profile was much tolerable in this group, and the grade 3 and grade 4 toxicity was much less in nivolumab group compared to the ipilimumab group. So this is the trial, and it shows clear benefit in terms of the overall survival. See, the separation of graph is quite outstanding. And again, when you use it with the combination with ipilimumab too, the group that got nivolumab stands apart on the top. On this trial, although which is not recommended in clinical practice, the trial runners did check presence of PD-1 ligand in the tumor cells or in the blood. Individuals who had high level of PD-1, it didn't matter whether you used nivolumab alone or nivolumab with the ipilimumab. But if they have a low titer of PD-1, they call PD-1 negative. In those situations, combination was superior to the single agent nivolumab. Again, checking for PD-1 ligand in tumor of the blood is not standard of care, but that was a subset analysis that trial did. This is the data that in ipilimumab in a stage 4 setting, and that they compared with the vaccine that time, because at that point vaccine was some encouragement in the metastatic melanoma. It came superior to the vaccine even when ipilimumab and the vaccine was combined, and that got FDA approval to have it used in metastatic setting. So the last part of that is targeted therapy. There are, as I said, 2 targeted therapies, c-KIT and BRAF. I'm not going to talk about c-KIT today. We'll mainly focus on BRAF. 2 BRAF targeted therapies available. One is called vemurafenib and another is called dabrafenib. And again, the BREAM-3, the phase 3 trial, again they compared that with standard chemo that time, and it did show that it has overall and progression-free survival. Whenever an oncological trial, especially in a disease this challenging to treat like melanoma, shows overall survival, that trial is truly well organized and good plan and has a gravity in the treatment benefit in that situation. Most common mutation in V600E, but individuals who had the V and K mutation, the benefit was present in later on in the subset analysis too. So basically anybody with the V600 mutation should be candidate for BRAF targeted therapy. So vemurafenib and dabrafenib was the approved agent to use anyone who has BRAF mutation. The challenge came, their response was dramatic. I think it even came in CNN, and one individual had a lung imaging showing numerous metastatic disease. 4 weeks after the treatment, there was only 2 left. The response was so outstanding. Unfortunately, what happened, the response was short-lasting. Within few months, their disease was coming back, and even coming back more aggressively compared to the before. And the second challenge was they started developing second malignancies like squamous cell carcinoma, keratoacanthomas, or second melanomas in that situation. The thought process at that point went that the individuals who has melanoma, they may have already altered MAP kinase pathway. So if the MAP kinase pathway is altered or mutated, if you block BRAF, they may find a second route to activate these second malignancies, and that probably happens with MEK pathway, MEK, mitogen activated kinase. So that time the focus was to develop a drug which can block the MEK pathway too. So the MEK inhibitor and BRAF inhibitor can be combined, and at that situation survival could be longer, toxicity could be reduced. So that's the reason it came with the trametinib, and recently in 2015 December, cobimetinib was published, and that showed better survival, better disease response compared to using dabrafenib or vemurafenib alone, and also it caused less cutaneous toxicity in both of these trials. Other toxicities, it can have diarrhea, unexplained fever of unknown origin. We commonly and regularly counsel our patient that it may not be related to the infection, it may be just related to the drug itself, and taking Tylenol and naproxen, the fever goes down most of the time. And vemurafenib and dabrafenib can also cause change in the ejection fraction in terms of the ejection fraction coming down. So it's recommended at the beginning to do a standard, regular EKG and echocardiography to say a baseline, and then follow and repeat the echocardiography or EKG as indicated, or approximately every 3 months. So these are overall cytotoxic effect of vemurafenib. The same toxic effects for dabrafenib too, so I didn't repeat itself. It can cause secondary tumors. As I mentioned, MAP kinase pathway being activated, and it bypassed the inhibition for BRAF. So when both of them were combined, the MEK and BRAF, at that situation, secondary skin malignancy significantly dropped. QT prolongation can happen. Many of these patients will be on drug for nausea like Zofran, or they may be in other drugs which already can cause QT prolongation. So it is important to have a baseline QT and then monitor closely so they do not get any cardiologically untoward effect. CYP3A4 inhibitors or stimulators could have an impact in the treatment. And again, trametinib has shown some effect on reduction of the ejection fraction, some dry screen and pyrexia like vemurafenib, but never similar or equivalent to vemurafenib. What are the treatment for immunotherapies? So those are the treatment for targeted therapies. For the immunotherapies, especially with ipilimumab, the toxicity is quite significant. When it was using last couple of years back, we used to have even patients coming with even bloody diarrhea, or thyroid problem or adrenal failure because of using these drugs. They can sometimes even cause hypophysitis. So they have pan-pituitary suppression. So their TSH goes down, their adrenal hormone goes down. The basic 3 principles in managing these individuals: interruption of the agents, that agent caused the problem, ipilimumab, stop that. Use corticosteroid. The dose of corticosteroid varies between 0.5 to 1 milligram per kg, depending on the toxicity. And all the time it is given IV, not orally. And at the end, we may need to give infliximab for immunosuppressive agent to stop that body's hyperimmune status, and that way the side effects can eventually taper off too. If somebody having significant colitis and even diarrhea related to the fresh blood coming out, colonoscopy may be needed to see the extent of inflammation, but the overall dictum of the treatment pretty much remains same. And these are the overall side effects. In a brief overview, what it can cause. It can cause endocrinopathies, so it can cause pan-pituitary failure, or it can cause autoimmune dysfunction of adrenal and or thyroid isolated way. And the mechanism workup pretty much same. You have to check TSH and see whether it is coming from the primary pituitary failure, or it is thyroid is hormones are leveled down because of the autoimmunity against the thyroid itself. There are strange side effects been reported. They can cause red cell aplasia, almost like a plastic anemia, and even acquired hemophilia A, which is quite uncommon to happen with any other treatment agent we use in oncology. At the end, it is most important from internal medicine standpoint was the surveillance for melanoma. For early melanoma stage 1A and 2A, again, they do not have no ulcer in the skin. The follow-up is pretty much history, physical, dermatological examination. Radiological examination not recommended unless they develop any symptoms which you may need to address. In stage 2B or metastatic disease, as the advanced stage goes up, at that situation probably there is a role of using imaging studies, but again the recommendation falls short of category 2B. So at the end of the day, it falls on oncologist's lap to decide whether the patient needs any follow-up imaging or not. So that's it. Questions?
So you have mentioned that in clinical practice we use 3 milligram dose of ipilimumab versus 10 milligram. So, but it was studied on 10 milligram dose in the trial. So will that not like a placebo versus relapse-free survival?
No. So to answer your question, there is one clinical trial done in metastatic setting back in 2010 that used ipilimumab 10 milligram per kg in combination with dacarbazine. Then when it was tested in the vaccine trial, they used a lower dose because they realized from the trial the side effects was too much. So the 3 milligram is the dose that FDA actually approved. From the past experience, researcher knew 10 milligram may provide better benefit. And in that trial, which combined ipilimumab with dacarbazine, the immune toxicity was less. Thought process is conceptually it was combined with a chemotherapy. So chemotherapy probably caused the immune suppression and the immune toxicity was not that high. In adjuvant setting, meaning in the curative setting, in a stage 3 disease, they wanted to use the highest most dose to get the best benefit. And that time they didn't combine with any chemotherapy. So the immune toxicity was not suppressed by any chemotherapy agents, and unfortunately probably side effects was too much.
So I think most of this is beyond the level of my question.
Not really.
What we will get as an exam in ABIM, just give us a couple of questions and all this.
I kind of agree and not agree, but this is not ABIM conference, so that's why I focused beyond that. It is really a CME for grand round purposes. For ABIM purposes, that only you need to know is when the sentinel lymph node biopsies need to be done, and which thickness and mitotic rate, and what's the stage if the lymph node is involved. As I said, it's next stage 3, and you need to know what are the side effects of ipilimumab, because it can present in the ER and they may call you, and you will not know this can come from immunotherapy rather than diagnosing that patient with ulcerative colitis. And at the end, what you need to know is surveillance. That's all.
You said that if the PD-1 immunotherapy chemistry is positive, in the Checkmate 207 trial, they actually put a cutoff on the 5%. Those patients with more than 5%, if the immunotherapy is positive for the PD-1, they have approximately 77% response to a combination of the vaccine therapy.
That's right.
As compared to those patients who are less than,
Negative.
So they have only 55%. However, you said that those patients who have a higher expression, it's not important in combination. However, it's more important that there is more response in those patients who have less than 5%. However, this Checkmate 207 just showed that those patients with a higher expression of the PD-L1, that is, they are more responsive to
Yes, you were right, absolutely, because it showed better response when the PD-1 was less than cutoff compared to using combination or single agent. But again, it was a subset analysis and it was not the primary goal point for the trial. And that's why there is no recommendation of checking PD-1 ligand level or the receptor level either in lung, which nivolumab has indication now, or in melanoma. But conceptually, can it be better? Yes, it is better. But if it is not standard of care to check it, I'm probably not going to check it in that situation.
And if somebody is there, what you're going to do? You're going to give this upfront or just kind of
So that's a very good question, and there is no definite consensus on that. So as ASCO and NCCN both says that if you are trying for immunotherapy, and the response criteria for immunotherapy is different, and I have not touched that point. So they may take months to develop any response that will be clinically appreciable. But if somebody has a higher disease burden and you want to reduce that disease burden quickly, it's probably better to use targeted therapy upfront and rather then go to the immunotherapy later on. So if a clinical oncologist who has a patient with a BRAF mutation positive and the disease burden is not much and decides to do the immunotherapy first, did he or she did anything wrong? No, there is no data to Oh yeah. I'm not disagreeing with you. What I'm saying, in 2010, we used to talk to our patients in terms of prognosis in weeks to couple of months. Now we have weapon to talk about months to year, which is an excitement. And somebody 45, even if you give them the toxicity picture and that months, they may have much more to live in that life for another 11 months. So, you know, that's probably the beauty of oncology, that we need to learn beyond the book, that beyond the clinical trial, what you actually need to do. I don't know at my knowledge at this point.